coronavirus circulates every year, causes respiratory illness, and spreads pretty much like the colds and flu. It's called novel because it's new. We all know it started in Wuhan, China in December of 2019. And the scary part about it was that when it emerged, because it was a new virus, no one had any immunity to it at all. Now that some people have been infected, we're learning about how much immunity people may have once they've been infected. It's believed that people have some short-term immunity. It may be 3 months, it may be 6 months. No one really knows. It's similar to viruses we've seen in the past, like the severe acute respiratory syndrome that was identified in 2003. And the Middle Eastern respiratory syndrome of 2012. Questions we asked early on was, am I at risk? And very early on, the big risk we were thinking was travelers coming from China, travelers coming from Europe. And so you can see from this slide that people were thinking that community spread was not a big issue. Well, we've certainly seen that that's no longer the case, that community spread is our biggest threat. And that's why, you know, the governor of our state has issued so many executive orders, making sure that large groups don't gather. We're taking protections in terms of, you know, mask wearing and really keeping ourselves protected and keeping other people protected as well. I want to stop here and spend a lot of time on isolation versus quarantine. This is where I spend a lot of my time. This is where contact tracing comes into play. When you talk about isolation, you're talking about people who are ill. Ill people, those are people that we call confirmed cases. We identify people who are ill predominantly through laboratory reports that we receive electronically through a state communicable disease software program. It's very confidential. We also get laboratory reports from physicians. We either get them by confidential fax or phone call. So once we identify people who are confirmed cases, we make sure that they are in isolation. We have to keep them away from the general population. They're isolated for at least 10 days. Even if they're asymptomatic, they are in the house for at least 10 days. We need to protect, you know, the general population. And we do a thorough case investigation. We will ask them from the time that you began to develop symptoms, go back 2 days, and we want to know everywhere you've been. We want to know everyone you've been with, and especially close contacts. Close contacts, our definition is someone that you've been within 6 feet for at least 15 minutes, and that's 15, it's now considered 15 cumulative minutes within a 24-hour period. And if we identify all of those close contacts, we're going to enter them into our database, and they're going to be contacted. So this is part of our contact tracing, and we will have contact tracers contact all of those people who are close contacts, because those are people who could develop the virus, and we don't want them circulating in the general population. So all of those close contacts need to be put into quarantine. So quarantine is when you separate those people and we restrict their movement because they've been exposed to the contagious disease. So because the incubation period can be between 2 and 14 days, 14 days is a full incubation period. We want those people who are close contacts to be in quarantine for 14 days. And that's a tough phone call to make because you were telling people, I know you're feeling good. I know you don't want to be put into quarantine, but you need to be in the house for 14 days. That means you can't go to work. You can't go to school. You can't go to ShopRite. You can't go to see, you know, your aunt. You can't go to a wedding. You can't go kids can't go trick or treating. They can't go to dance class. Everybody's in the house. And they, you know, a lot of people want to have a debate. They want to, you know, say, no, 14 days is 7 days. No, it's 14 days. So, so that's a tough phone call to make, but that's the way it goes. Does anybody have any questions in the chat box?
I will
Okay.
take a look right now. We have no questions. I do have there is one question right now in cold and flu season. If somebody does have symptoms, how do they need to get tested right away for COVID if it's, you know, a cold symptoms in cold season?
So if someone has symptoms, the symptoms now for COVID-19 can be very nebulous, and they can be similar to the flu. So someone who goes to see their physician will probably get tested for both. They'll get tested for COVID-19, they'll get tested for the flu, and then that'll be their differential diagnosis in all likelihood. And because they're both viruses, chances are that they would be given, you know, a Z-Pack, because that would probably work for both if they're positive. So, and of course, everybody should be getting their flu shot. So moving on, active monitoring versus passive monitoring. Active monitoring is when someone other than the individual who's in quarantine is doing the monitoring, and it can be electronic. We have a new app that can be downloaded that can push out messages by text, or that can actually see when you've been in close contact with somebody. And it's very discreet. You don't have to find out who the person was that you were in contact with. Early on, we were doing things like making phone calls twice a day to monitor people's symptoms, but now it can be done electronically, which is great because it's more privacy. Passive monitoring is somebody just taking, you know, their own temperature and monitoring their own symptoms.
Helen, I have a question.
Mm-hmm.
The question is, I've heard there have been quite a few false negatives. Should you get retested after you've been sick with almost all of the symptoms?
So that's really up to the individual. False negative, it depends. There are several different types of tests that are available now. There is a rapid test, which is not as precise as the
That
PCR
just answered, because we had another question just now about rapid tests. Thank you.
So rapid test is great because you get the results immediately, which is wonderful. But it's not as sensitive as the PCR test, which is considered the gold standard. And there have been people who have gone in and gotten the rapid test, and then they've also had the PCR done the same day. So maybe your rapid test may have one result, but if you get the PCR test within 48 hours, the PCR test will cancel out your rapid test if it's done within that 48-hour window. So PCR is always better, but you know, like if you want to get your child back in childcare, you know, people will go that day, and this way they can go back in, and especially sports. People are, you know, crazy to get back into your sports team. So just looking at influenza, I mean, the case counts for people who are affected by influenza, it's just crazy. 45 million cases in a season. It's a lot higher than the people who are afflicted with COVID-19 so far. And deaths are very high for influenza also, not as high as for COVID-19, but we know a lot more about influenza, and we have a vaccine. With COVID-19, we were really caught unaware, and particularly with the older population, they were predominantly afflicted by COVID-19, and we've now learned, you know, some better ways to protect them. So hopefully, you know, we've turned a corner in terms of our learning. It's just been an evolving situation. And as I said, you know, these slides were developed early on. Hopefully, you know, a year from now, we're going to be in a whole different situation. Talking about signs and symptoms, again, this is where we were in March. We were looking at a respiratory illness. We now know that it can also be a gastrointestinal illness. And one of the other unique features of COVID-19 is people finding that they've lost their sense of smell, they've lost their sense of taste. And that's one of the hallmarks of this illness. Treatment, back in March, they were treating the symptoms. Doctors in the hospital were really kind of, just trying whatever they could, trying to figure it out. We now have some drugs that have been developed. Remdesivir has been approved by the FDA, and we have monoclonal antibodies, which are in clinical trials. And hospitals, I think, have learned a little bit about when to put people on ventilators and when not to. So again, they haven't come up with, the miracle cure, but they're learning, and they have a couple tools in the toolbox. How does the virus spread? It spreads through the air, coughs and sneezes predominantly, droplet, and people believe that it could also be airborne to a lesser extent, touching objects and surfaces and then touching mucous membranes, close contact with people who are ill. We talked about the incubation period, up to 14 days. There's a lot that we don't know. How can we prevent the spread? Hand washing, definitely. Covering your coughs and sneezes, staying home when you're sick, all the things that we already know, but we just have to be, more vigilant. Should we wear a mask? You've got to wear a mask, especially if you can't maintain the 6 feet of distance. 6 feet is, you've got to, when you can maintain the 6 feet, you just got to do it. Here's a picture of somebody on a subway that you're not getting 6 feet. No way. But a mask, it serves some protection. It protects other people from your respiratory secretions. It's mandated that you must do it. You're not getting into a grocery store unless you're wearing a mask. So it's not even should you must do it.
We have a question. So lots of times you go places and they do a fever scan to make sure that you don't have a fever, but you can have COVID-19 and not have a fever. So what extra precautions can somebody take?
So some of the things that I've seen, like, oh my gosh, when I went into the Apple store, I felt like I was going into a hospital. Not only did they take my temperature, I had to fill out a chart to, have I had, any of these symptoms? Have I had nausea, vomiting, diarrhea? This is just to go and look at an iPhone.
Right.
So, so those are all good questions to ask because, have you had loss of sense of taste or smell? Those are all, symptoms, and, checking the fever is really, that was a symptom early on that a lot of people were having. It's been more subtle lately, fortunately. It's never a bad idea to check. I mean, it makes people feel a little bit better, but I think that the more people are aware that, if you're having, diarrhea, and you're having all these other symptoms, and especially the loss of taste and smell, maybe you shouldn't be going out. Maybe you should be going for that test. And testing is much more widely available. Early on, it was a problem. They were saying, don't get tested unless you have symptoms. Now, it's really widely available. So, there's no reason not to get tested if you have any concerns. So just, flashback, like, what is that, Flashback Thursday or whatever it is? So,
Throwback Thursday.
China, I don't think anybody's planning to go. So here, talking about what happens if you're coming back from China? Now, what happens if you're coming back from Florida? You're not allowed to go to Florida, Delaware, Pennsylvania, Texas. You have to be, now if you're going to any of those other states, you need to be quarantining for 14 days like you had to do from China, and now it's going to any of those other states too. And going to those other states, it's not mandatory, but it's really expected. It's expected just to maintain the safety of everyone. And who should be tested? We talked a little bit about this early on. Testing was only being done at the public health laboratory. Now it's everywhere. So we're very fortunate. What is the Department of Health doing? Oh my gosh, they have been working like maniacs. They put out guidance for everything. Local health departments, the schools, and it's updated all the time. Schools, daycares, restaurants, public bathing, pools. I mean, every place that you can think of has a guidance document. And they're very complex and they're updated all the time. So in addition to doing all the contact tracing, they're working so hard. They're doing daily calls with my group and with other groups. So you really hats off to them. They're working so hard. These are some places where you get information, but by now everybody has their go-to sites. Any other questions?
Let's see for questions. Okay, here's a question. If I get tested for coronavirus, who will my positive result be reported to if I test positive?
So any positive results are sent electronically to the local health department where you reside. And then that local health department should call you for a case investigation. And then any contacts that you provide them with, close contacts, and I hope you will. Oftentimes, you know, people are reluctant. They don't want to get anybody in trouble. And this happens a lot more with children, and especially teenagers, 20-year-olds, especially if there's been a party and they don't want to get the other parents upset that they told that somebody else was at a party. They shouldn't have been at a party. But that's how you can stop the spread. And, you know, you just gotta, you know, give up the information. We're not going to tell anybody, you know, that you were at a party. It's all confidential. The only people who are going to be telling are the people on Facebook, not us.
That's true. Okay, I'm looking for more questions here. We have no more questions at this time. Call for questions. This is your opportunity to get a face-to-face with a public health nurse. Going once? Going twice? Okay.
Thank you, everybody. Have a great day.
Now, if you stop your screen share, we will pass this over to Courtney Sartain, MPH, Epidemiologist for Warren County, New Jersey. Welcome, Courtney.
Thank you. All right, I think that I am sharing my screen. Can everybody see it?
Not yet.
Okay. It's showing for me.
Okay, let me just double check. Thank you, everybody, for living with us. I got somebody on the chat. It must be a tech-savvy person telling us how we could better do this. Here it comes.
Oh, okay, great. Awesome. Okay. All right. Okay, can everybody see now?
Yes.
Awesome. Okay, so hi, everyone. I am the public health epidemiologist for the Warren County Health Department. In Warren County and in a couple other counties across the state, they have only a county health department. In other counties across the state, there is both a county health department and other local health departments that cover certain jurisdictions. So in my case, I cover the entire county. And ultimately, I hope to be sharing information with you that I work with on a daily basis, Helen works with on a daily basis, and our job at this point in time and at every point in time is ultimately to stop the spread of disease. So if we can share information with you all, we hope that you can be our communicable disease warriors and also help the spread of disease as well. So Helen did talk about this a little bit, but clinically speaking, when we're looking at the similarities and the differences between influenza and COVID, the similarities include that fever, some respiratory illness, and also cold-like symptoms. We see these symptoms very prevalently in both flu and in COVID. And as Helen mentioned, the distinct difference between the two is this unique loss of sensory deficit, the loss of taste and smell with COVID-19. So really, when people are calling my office and they're asking, you know, I lost my taste and smell, should I get tested for COVID? We are absolutely saying yes. That is a very unique symptom to COVID-19. And so I am constantly looking at the New Jersey Department of Health COVID-19 disease chapter that is updated fairly often by the New Jersey Department of Health, and it has all of this information that I'm presenting to you. You can also read right from that disease chapter, but it is something that I am working with day in and day out. So when we're talking about a clinical case of COVID-19, just based on clinical presentations, we're looking for someone who has 2 of the following symptoms, and you can read this list here, or one of the following symptoms, including cough, shortness of breath, difficulty breathing, or loss of taste or smell. So when someone is presenting with these symptoms in the absence of a more likely diagnosis, we are going to say, hey, we think you should go get tested for COVID-19. And if somebody discloses that they had an exposure and then has developed these symptoms, we're absolutely advocating that they go to get tested. And so there's a couple case definitions that I want to go over with all of you because I think that they're really important. I know that every week I'm publishing a report from my county that includes confirmed and probable cases. And so I just wanted to share the difference between those two. So if you were a confirmed case of COVID-19, you have received a positive result with a PCR test that Helen talked about earlier, and that is the gold standard for testing. So whether you are symptomatic or not, if we receive a positive PCR test with you, you are considered a confirmed case of COVID-19. If you meet presumptive laboratory testing, which means you've received a positive rapid test result, we consider you a probable case, whether you are symptomatic or not. And also, if you decide not to get testing, if you have an epi link, so if you've been named as a close contact or been exposed to someone who had COVID-19 and you have symptoms, you don't even really need to go get tested. You certainly can, but we already treat you like you are positive based on that information of having an exposure to a confirmed COVID-19 case and symptoms. And then possible cases. So sometimes you go to get tested for COVID-19 and the person doing the sample, or if you're doing it yourself at a lot of these different testing locations, people are doing them themselves. You might not get a great sample. You might not get enough sample on the swab, and therefore when they test it in the lab, it might come back as an inconclusive test result. So in New Jersey, you have 48 hours from your initial specimen collection to get retested, and whatever that result is will cancel out your inconclusive. If you receive your test result as inconclusive and you are 3 or 4 days out of COVID-19 of getting your initial specimen collected, we treat you as positive in New Jersey. So that means we are going to call you, we are going to let you know, hey, your lab sample came back inconclusive and you're out of the window to get retested. Because inconclusive means there was a little bit of COVID RNA typically found on the sample, we're going to treat you like you're positive, which means we're going to give you isolation guidelines and we are going to quarantine your close contacts. I can say that does not happen very often, or at least it hasn't happened very often for us in Warren County, but it does happen occasionally. And under that definition, we would consider you a possible case only because your test came back inconclusive and you might not have been able to get retested in that 48-hour window. We have been hearing about high-risk populations in the media. You can all take a look at these different high-risk populations. from the beginning, we have been really focused on older adults as well as people with underlying medical conditions. We know that COVID-19 can greatly exacerbate underlying medical conditions, so we are always talking about precautions that people with underlying medical conditions can take in order to protect themselves. And also in the news, there's been a lot of talk about racial and ethnic minority groups getting COVID at a higher rate than others, and also dying from COVID-19 at a higher rate than others. So as an epidemiologist, I'm constantly looking at outbreaks. I'm constantly looking at clusters. We are really trying to see if there are a couple COVID-19 cases tied together that ultimately we can say there has been spread amongst a specific population. So we have been watching the long-term cares across the state very, very closely. And so you can see what we classify as an outbreak for all of these different settings. I can say specifically our long-term cares in Warren County got hit really hard in the beginning, and I think all of the long-term cares across the state of New Jersey really got hit hard. But at least in Warren County, we've been doing really, really well. Our directors of nursing at all these facilities have really made it their mission to really protect the staff and the residents, and we are seeing fewer and fewer cases in long-term cares. For about 3 months, my long-term care facilities were outbreak-free and COVID-free. So it's a huge accomplishment for them, and I'm very, very proud of them. I can also say, in the school setting, although we have seen COVID-19 cases in the school setting, in Warren County, we have not seen any secondary transmission in the schools, meaning that when we have a COVID-19 case and we exclude other cases, other people as close contacts, we are not then seeing any of those close contacts test positive for COVID-19, which means that the schools are doing a really great job with their social distancing and masking protocols. And I'm also, schools across the state have been doing a really good job, but specifically in Warren County, I'm very proud of our schools as well.
Courtney, as related to children, we do have a question.
Sure.
Are there different test techniques? And the concern is, it's very hard for a child to have the deep nasal swabbing. So do you have any comments on that?
Sure, absolutely. So when we first started testing for COVID-19, we were using the nasopharyngeal swabs, which are the ones that people joke about tickling your brain. They go pretty far back. Since we have expanded testing, I know that doctors' offices are using oropharyngeal, which are in the throat, and they are also using nasal swabs, which are just right inside the nose. And those nasal swabs can either be administered by a clinician or they can be self-administered. So those nasal swabs are great for children, and they're much less invasive than the initial nasopharyngeal swab. So a little bit about COVID-19 related deaths. I know that this is a really hot topic across the news. So the CDC is reporting a total of a little over 200,000 deaths attributed to COVID-19 in the United States. When people are dying, the cause of death is being determined by the certifier, which is either the physician, the medical examiner, or the coroner. So I was trying to look to find some exact data, but initially the CDC had published some data about how many people died from coronavirus only versus how many people have died from coronavirus that exacerbated pre-existing health conditions. And I think by and large, we are seeing people absolutely die from COVID-19 alone, but it definitely can exacerbate underlying health conditions and absolutely attribute to someone dying. And so I put in a couple slides from the report that I publish every week. And so you can see our deaths in Warren County have leveled off. It looks like I haven't had a new death in Warren County since August 4th. So it's been over 2 months, and I have not had any new deaths, which is awesome. I'm very happy to report. The top line is total deaths, and then the bottom line is deaths that were attributed to our long-term care facility residents. So the long-term care facility deaths make up about 80% of total deaths in Warren County. Warren County has the highest case fatality rate in the state of New Jersey, and I will cover that in a little while. So a little bit about laboratory testing. Helen did touch on this too. I also see a typo. But so the PCR test is really the gold standard for detecting active COVID-19 infection. There have been a lot of rapid antigen tests, these point of care tests that have popped up at doctors' offices and urgent cares across the state of New Jersey, and I think across the country as well. I'm not super sold on the rapid antigen testing. I think by and large we get excellent results from the PCR tests. Like Helen did mention, we do see a high rate of false negatives with the rapid antigen testing. False positives, though, are unlikely. So when we are getting a rapid antigen test reported to the health department here, we are taking that at face value and we are moving forward, unless somebody is asymptomatic, and then we talk about sort of getting them retested. And then so there has been a lot of talk about antibodies and serology testing. And so I think it's important to note a couple of things here. So you cannot get an antibody test and say that you don't have COVID-19. If you test negative for antibodies, that does not rule out active infection. If you test positive, it may reflect another coronavirus antibody in your system. So currently, as we speak, there are only 4 antibody tests that have been reviewed and approved by the FDA. All other antibody testing has been granted EUAs, which means they are allowed to use them, but we don't really know what the results mean. So while I wouldn't discourage anybody from getting an antibody test if they were truly interested, the data is really limited. We have no idea right now what level of antibody is needed for protection or what level of antibody is even being detected through these tests. So the jury is really still out on these antibody tests, and I caution at the interpretation of the results.
So there is a question, talking about an antibody test may reveal that there had been some previous exposure to a coronavirus. So when you talk about, coronavirus and cold and flu season, again, what advice would you give everybody on general cold symptoms at this time?
Sure. So I think general cold symptoms are pretty common during this time. When we are really advocating for people, we're never going to tell someone not to get tested, but if you have a known exposure and then you develop these cold-like symptoms, we're going to say you should probably go get tested for COVID-19. I believe there are 4 naturally occurring coronavirus strains in the world. So when you're getting tested for a respiratory pathogen panel or a respiratory viral panel, coronavirus, these other strains of coronavirus that we know about and that have been around and are similar to colds and flu symptoms, these antibody tests might be detecting those antibodies and not antibodies for COVID-19.
Okay.
And so this is just some of the testing data that I have been able to pull for Warren County. So we've received 25,000 results total for our residents. That's that top blue line. The line just below is the negative results. So it looks like we've received a little over 23,000 negative results for our residents. And then this bottom line that's hovering a little bit over 1,500 is our total positive results that we have received for our residents. And those are individual results that have been received. So this is also something that I really look at as an epidemiologist is incidence rate and case fatality rate. So the incidence rate, which is very hard to determine with something like coronavirus, COVID-19, because the denominator in this situation is always changing. But the incidence rate is the number of new cases of disease divided by the number of people at risk of the disease. So arguably everyone is at risk, but when you, so this bottom number is always changing. And then our top number is how many people, at least what I'm looking at, is per day are getting are coming back positive for COVID-19. Laura, you have a question?
No question.
Oh, okay.
Nope. Thank you.
And then so the case fatality rate, which is very interesting, is the proportion of people with a specific condition, in this case COVID-19, who die from that condition. So it's the number of people that die divided by the total number of people who are infected with COVID-19. And so you can see this chart is from last week, but you can see we're looking at population density, case counts, crude incidence per 100,000. So this is that incidence rate that I was just talking about. And you can see that, you know, places like Essex County, Hudson County, Passaic County, the more densely populated areas have a higher incidence rate. Warren County has been clocking in at number 18 out of 21 in terms of incidence rates. Although as you can see in the furthest column, the CFR, the case fatality rate, Warren is number one, has the number one highest case fatality rate in the state of New Jersey, followed closely behind by Sussex County, and then Cape May and Somerset County as well. And so one of the things that we are really looking at is the positivity rate. So the percent of positive tests divided, so the number of positive tests divided by the total number of tests. So Johns Hopkins had come out and said that if your positivity rate is below 5%, you're likely finding, you know, you have enough testing, you're likely finding all of the disease that is sort of out in the population. If your positivity rate goes over 5%, you should really boost the testing, the supply for testing, because the demand is higher and we might not be catching all of the disease in the population. So in Warren County on October 18th, the positivity rate was 1.73%. While in the state of New Jersey, the governor reported that the positivity rate on the 18th was 5.28%. And so we also see this, this rate of transmission, this RO factor that the governor talks about. Other sites across the state and the country are also publishing these rate of transmission factors, and they don't always seem to match up. So I'm not sure how they're all being calculated. But really, we're looking at this number to really quantify the spread of disease. So when the governor in New Jersey says that the rate of transmission was 1.18 in New Jersey on October 24th, he means that for every new infection of coronavirus that we are seeing, at least one other new infection is coming from that. That's really important. You know, back in the thick of things, we were seeing that RO number be, you know, 5, 6, 7. So for every new infection, 5 other people were also being infected. That is very high. So it is good to see that number has come down significantly. Although I did hear the governor yesterday say that the rate of transmission is rising again in New Jersey. This is, you know, a little graph that I published for my report in Warren County, and that can be found on our county website, which is co.warren.nj.us. I do a weekly report every week and include some of this relevant data for our stakeholders and the public, so that they know where we sort of stand in terms of our weekly COVID-19 infections. And so you can see at the height of things, we were about at 47% daily positivity rate, that means almost 50% of the people that were tested during that time were positive, which is quite high. And so, before I wrap things up, I just wanted to talk about sort of what we know in terms of the COVID-19 vaccination. So I know that Governor Murphy and Commissioner Persicelli did release their COVID-19 vaccination plan yesterday. I have not had the chance to read it in its entirety yet. But there are 2 vaccines that are anticipated to be released first. Those are by Pfizer and Moderna, and both are mRNA vaccines. There are currently no mRNA vaccines licensed at this time, but these vaccines will be used to boost immune response. So we're expecting that these vaccines will need 2 doses, about a month apart. And we do know that we are going to be definitely prioritizing these groups of people. I anticipate that long-term care facilities, healthcare professionals, first responders, and seniors, in addition to people with high-risk conditions, will be considered first for the vaccine. And at this time, we are not anticipating on vaccinating children, as there has been no emergency use authorization granted for any of the vaccines that are currently being trialed for children. Questions?
So here's a question. If parents are getting vaccinated and children are not being vaccinated, are we really going to be able to get this under control within the juvenile population?
So I think right now the goal for New Jersey is to vaccinate 70% of adults, which is a huge undertaking. And I believe we are going to do that in the first part of, or we are going to try to do that based on vaccine availability by the beginning of next year. And I think while we're creating an immune response in adults, I certainly think that will help the spread to children. So I think that is one thing that we're looking at. I think that eventually children will be able to be vaccinated and we will get it under control in the adolescent population. I just don't think it will be as quickly as we do for adults. And I also think, anecdotally, we are seeing children who are just spreading disease. We are seeing a lot of children who are asymptomatic and just spreading, although we do see children that do have mild illness as well. So, yeah.
Now that would be typical with any virus or any type of infection with, young children. It's very typical in childhood anyway, right?
Right.
Yeah. Okay, any more? I don't see any more questions. Okay, any more questions? Going once, going twice. Okay, we have no more questions. Okay, so if we have no more questions, I would like to thank everybody for coming today. If you do have questions after we disconnect and you say, oh, I should have asked that question, please email me at laura@njhealthmatters.org. You could visit us on the website, www.njhealthmatters.org, and within a couple of days, we are going to get the meeting materials from today up on our website. This recording will go up, as well as any slides that our presenters wish to share. We have one thing in the chat. Let me just see. Thank you, Courtney. Terrific. Okay, thank you. That was really educative. Thank you, thank you. Thank you all. So I would like to say these women are so busy. They are on the front lines every day protecting our public from this pandemic. So thank you, Helen, and thank you, Courtney. I know you both have to get back to work. We are grateful for all that you do and all that you have been doing. So everybody have a great day. Thanks for coming.
Thanks, everybody.
Thank you.
All right, bye.
Bye-bye.